And I'd like to give a floor to Sergei Vorobyov, the morphologist. He's a member of our interdisciplinary team, and without successful and reliable work of pathomorphologists, our team doesn't feel comfortable. We cannot move forward. That's why we asked Sergei to share his information concerning morphological part of those issues. Thanks a lot for presentation, introduction, and participation in this conference. I'm preparing to the conference. I was sure that one of my main tasks is to convince the audience that the most complex task, or what we're talking about, it's a morphologist task. But now, looking at this international group, I understood that our work is complicated, but others, the work of others is not also very easy. And I would like to start my talk from finding out that there is some evolution in our understanding what's going on in the pancreas. It changed our point of view. Therapists, they know this classification, we used it for many years, and we had quite a clear understanding that things are not very easy, because calcifying and obstructive pancreatitis were often associated with alcohol abuse and intoxication, and things seem to be not very complicated. But as long as we expanded our knowledge in those disorders, we saw that there are some other disorders in pancreas, and they are quite frequent. It's fibrosing disorders, which are quite often autoimmune. One of the forms which was mentioned, it is a pancreatitis associated with IgG4 immunoglobulin production or hyperproduction. And I started with pancreatitis because it's not a diffuse lesion, but it could be a lesion of a tumor-like type. And on microscopy, we see not a pancreatitis, but a tumor process. And that's how it looks, this complex morphological pattern on surgical material. Well, we can see everything here. It's both adenocarcinoma and potential it's lymphoma, but all these things, it's a consequence of pseudocarcinomatosis pancreatitis. Then FNA and EUs, it moved us quite considerably in the diagnosis of tumor and non-tumor pathology, and indications in oncology are as follows.
This is diagnostics of solid and cystic malformations, and also the taking decision on surgery. Advanced non-resectable tumors, we should understand the target therapy modalities or chemotherapeutic opportunities, and finally, it also enables us to understand that the pancreatic tumor can have metastasis or secondary metastasis, and sometimes it is quite a surprise. And I will show such examples to you. In our pathological practice, routine practice, we use several fundamental manuals or guidelines, so to say, and one of them is WHO classification of tumors of the digestive system, which is based upon it is an expanded version based upon not only morphological diagnostics, but also certain clinical X-ray signs of tumors, which we also come across. And there are certain signs of molecular biology, so to say, which I suppose is our future, both in terms of verification of diagnosis, tumor or non-tumor diagnosis, and also all the problems related to target therapy. What is this WHO histological classification of tumors? This is a list of oncological disorders, which can occur in the pancreatic gland, which is subdivided into three groups: benign, borderline, and from the same type of epithelia, and also a wider, more expanded group of malignant tumors. And mainly we speak about ductal adenocarcinoma, which is very prevalent, and which is a group of oncological tumors with heterogenic properties. And the question that I asked to Mikhail Sergeyevich, to the previous speaker, was related to this group of tumors, because when we talk about adenocarcinoma of the pancreas, we sometimes understand it as an abstract, malignant, epithelial, progressive disease. But indeed, this pathology is a typical ductal adenocarcinoma with different differentiation extents, or high and low, like all the adenocarcinoma, and mild or moderate. And apart from that, there is a specific ductal adenocarcinoma, the mucinous non-cystic carcinoma, signet ring cell carcinoma, adenosquamous carcinoma, undifferentiated or anaplastic carcinoma, undifferent carcinoma with osteoclast-like giant cells, and some mixed ductal endocrine carcinoma. Apart from the ductal adenocarcinoma, which originates in the main ducts of the pancreas, we can also come across adenocarcinomas or tumors with different extent of malignancy and different biological potential, which can have cirrhotic origin, mucinous origin, as cystadenoma, adenocarcinoma, which we have already mentioned, a non-invasive or invasive type of lesion. And in this situation, we can come back to the question that I asked. We should understand it very well, that for the formation of advanced, irreversible cancerous process in the pancreas to happen, there must be some time to form, for the adenocarcinoma to form. And this time, if compared to other adenocarcinomas, it has certain borders or certain limits, like the colorectal carcinoma. Until it develops into the low differentiated or undifferentiated carcinoma, it has to undergo this Corey cascade, which can last from 2 to 15 years. So most probably, in relation to the pancreas, we have certain time reserve within which we should understand certain process should be happening. And I quite agree that something should be done for us within this more or less safe period to detect this adenocarcinoma by means of classifying patients into the risk groups and introducing certain screening modalities. So intraductal papillary mucinous carcinoma, non-invasive, because the pancreas as an organ is an exocrinic type of organ which produces a number of enzymes and biological substances. So the main cell, producing cell, is not a ductal but an acinar cell. So acinar cell carcinomas are quite popular, and also some solid-pseudopapillary carcinomas can occur, but these are rare type of tumors. Also mesenchymal tumors are listed here, or some other secondary tumors or lymphoid type of tumors. And if we speak about pancreas tumors, then we can subdivide them into bigger parts, two big parts, the solid ones, which are very difficult to verify by some additional diagnostic modalities. They can be differentiated only when they are of big size. And most probably we speak about ductal adenocarcinoma, chronic pancreatitis, or metastatic lesion. When alongside with the solid component, we also have cystic component. We can speak about neuroendocrine, cellular and other types of tumors. So ductal carcinoma as most aggressive and fast progressive type of tumor. In this slide, It shows all three types of differentiation. The high differentiated ones with a tubulation signs, when it loses its signs and becomes moderately differentiated, and when it grows as infiltrative tumor lesion, and it is low differentiated or no undifferentiated. Low differentiated carcinoma. This is either post-mortem or surgical sample. You cannot help this patient, but there are certain adenocarcinomas with such epithelial changes. The structural and the epithelial neoplasia is not big, is not manifested, and pathologists run into problems. As there are no anchor principles that can help you to verify the process as adenocarcinoma, but not hyperplastic process. If we speak about ductal carcinoma, one of the groups that you should detect is risk groups associated with somatic mutations, such as, where the risk of pancreatic carcinoma is very high. There are 5 main groups. There are many more, but I am going to show only 5. These are Lynch syndrome. Patients over 70 develop in 4% of the cases. Ductal carcinoma, familial forms of breast cancers from 3 to 10%. Familial pancreatic cancer. Patients of advanced stage almost in 40% of the cases, like in the so-called inborn pancreatitis. It's about 40% by the age of 60, and the Bates-Yeager's syndrome, very high percent, 60% in patients at the age of 70. Thus, we can form the risk groups. Acinary carcinoma. The main mass of the pancreatic gland has these cells. So when we have these cells, it is this type of tumor. It is not problematic for diagnostics in the preoperative period, but when we speak about this type of tubular carcinoma, or when there is no signs of differentiation, like, some glandular tissue, then this particular carcinoma will look like endocrine tumor or some other types of tumors. In the fluorescent microscopy, you cannot differentiate this carcinoma at all. And also mixed acinar and ductal carcinoma, when you have both glandular and mucinous type, as well as the solid type of acinar carcinoma, cirrhotic cystadenoma or neoplasia. It has very typical manifestations in the ultrasound. You can recognize it, and that is why the biopsy from this tumor is not sent very frequently to us. A surgeon calls us and tells us that most probably this is a cirrhotic type of neoplasia, and most probably it is really like this. This is a benign process in many cases, and it does not transform into malignant process very frequently. And a very rare pathology, the solid-pseudopapillary tumor, which we came across 2 or 3 times already, and we're not only reading about it nowadays, but also can see it. When we speak about the second group of pathologies in the pancreatic gland with certain cystic formation, this is quite a frequent pathology, and you should understand that it could be pseudocyst or some cystic, even large cysts, or small cysts, lobular cysts can also occur that need differential diagnosis, because they form their structures with absolutely different biological potential in terms of progression. That is why in the cystic malformations, the diagnosis is so important, and it's very difficult for a pathologist. Macroscopic variants of neoplasms, you can see here encapsulated malformation with very thick capsula, which turned out to be a mucinous neoplasia, cystic neoplasia, and also intraductal tumor, which again is quite problematic for morphological verification. So, diff diagnosis of cysts is very difficult because of the multiple etiologies, but the main difficulties in morphology come when we speak about mucinous cysts, and you should differentiate between IPMN and MCN. I think the surgeons are aware of these guidelines dating back to 2012, quite fresh ones, which subdivide these mucinous neoplasias into two groups with high risk stigmata, that it's already a malignant tumor. There are no biopsies here because, generally speaking, there's three clinical signs that you should take into account, and they are quite sufficient in order to take decision that the patient is surgical type. And also, when we have a cyst up to 3 centimeters, certain thickening or changes in the cyst walls, when the main duct is smaller than 10 millimeters, when we have some mural nodules, or when you are faced with abrupt change in MPD size with a distal pancreatic atrophy. In these cases, we have EUS FNA modality because it is a worrisome feature. And if you have suspicion, you should take decision on whether to send patient for surgery or not. So subsequently, we are faced with the problem of diff diagnosis, whether it is mucinous neoplasia or not, and second, if it is mucinous, then whether it is associated with high or low malignancy potential. As the operating theater is awaiting for us, so please interrupt me if I need to stop to come back to. No, that's okay. They're still actually in the process of inflating or deflating the balloon, so don't worry. How do we implement this diff diagnostics? So the content of the cyst that, again, we talked about today as a native material should be provided to the morphological laboratory. Second, while examining this or examining this specimens, we should use certain morphological methods, and we should conduct all the necessary examinations that have already been mentioned. With the necessary examination of the pre-cyst malformations, this is quantification of the amylase and KRAS mutation, which I'm going to talk about later on. So, elevation of CEA, especially significant one, shows that it's probably a mucinous neoplasia, but nonetheless, it allows us to do the diff diagnosis, and the high level over 1,000 of amylase shows that it's a cyst, and quite significantly. But you should understand that if the amylase has very low value or it is absent, then you can exclude the pseudocyst, even if it shows like that in the imaging, and it doesn't allow us to differentiate these mucinous neoplasms. What helps us in diagnostics is molecular genetic studies, but not the somatic ones, which I mentioned in the first part of my talk, which are helpful in detecting the risk groups, but the point mutations that happen in the neoplasm themselves, in the tumors themselves. And first of all, well, here we're talking about KRAS. If there is a mutation in it, that means that there is a tumor process, but the diff diagnostics is impossible even if you detect the RAS mutation. You also need to detect the beta-catenin, which is the mutation showing the cirrhotic neoplasms, and other mutations that you can also detect in the Russian Federation. At the moment, this testing is not done, even in specialized laboratories. Next group, or endocrine type of tumors. If previously we thought that it's quite simple, because you just need to calculate the mitosis or Ki-67, calculate the approximate activity of these processes, and subdivide it into 3 categories: either G1 with low malignancy potential, either G2 with moderate malignancy grade, or the neuroendocrine tumors should be referred to endocrine carcinoma. I mean NEC, which is associated with Ki-67 below 20%, which can be large cell and or small cell, like in the lung cancer, and large cell. Again, diagnosing this is impossible without immunohistochemistry. And as a matter of fact, they're hyperproducing in terms of hormones. At the moment, we step aside from the immunohistochemical typing of neuroendocrine tumors because it's very difficult. It's very easy to detect all this in the blood serum. So we want to avoid additional testing, excessive testing, in order to not to overuse the resources and the knowledge for solving a simple task. So materials for the morphological assessment, and you can see here the sensitivity. If you use EUS FNA, it's 85%, and it shows the link between the size of the tumor. It's clear actually that the bigger the tumor is, the higher the sensitivity is in verifying the process. The smaller the size of the tumor, the less it is dangerous for the patient, the more difficult it is to describe in terms of morphology. Then, if we speak about brush biopsy, then this is the data that was demonstrated by the European Association, but generally speaking, according to our data, this will be significantly lower. Intraductal aspiration, 66%, or core biopsy. In different settings, the sensitivity will depend mainly on where the examination is performed, or the testing is performed. When it comes to the samples which is submitted for morphology, during referral, there must be clinical data in the accompanying documents, demographic data, then full history, and clear understanding of radiology or radiological method of investigation. Otherwise, it is impossible to do the deep diagnostics in morphology. And if there are some additional tests done, then also they should be submitted to us. If we speak about pure cytology, and at the moment, even in specialized settings which deal with pancreatic tumors or gastrointestinal tumors, the main morphological method is cytology. This aspartate material in 5, 2, or 3 slides. And generally speaking, the classification proposed by the Association of Cytopathologists named after Papa Nicolau. This is the terminology, and I will read it to you. I will read it out to you, and you will tell me whether you are satisfied with it or not. No diagnostic value, negative. Then further on, atypia of unknown origin, neoplasia. What kind of neoplasia? Benign tumor. A cytologist shoulders this responsibility to state that it's a benign tumor, but there is no diagnosis. Still, other type of lesions, pancreatitis or some other processes, then if a cytologist is very confident, he might state suspected tumor or positive malignancy. And what do we have as a result? As a matter of fact, the cytology, isolated by itself, is not capable of solving the diagnostic task as part of the detection. It's clear that things get simpler if we speak about bigger malformations or advanced forms. If it is about tumor is about 4 or 6 centimeters with the metastasis into the lymph nodes, wherever you take an aspirate from, you get the material, and on cytology this carcinoma can be identified, but it's not of any practical relevance for the patient simply because the patient cannot be helped. So this classification and this isolated method of testing is not useful for small or borderline type of tumors. I mean borderline between tumors and non-invasive carcinomas. I cannot but speak about the intraoperative testing. I'm very happy to hear from an oncologist today that we do not need any emergency testing intraoperatively. I'm very glad to know this, because the deep morphological diagnostics in the majority of the cystic or tumor processes, it doesn't have any value. Intraoperative testing is done from the, or just biopsy is done from a very small site of the tumor. And if the surgeon can smoke for an hour, for instance, and it's still not more than 1 to 3 biopsies, then there will be manifested deformity, tissue deformity of the gland, because of the use of very low temperatures. Although the main cytology samples or emergency cytology is done in cryostate slices or cryoslices at the temperature of -10 to -15 degrees, which complicates the diagnostics further on. And it's of suspected nature, which is not very useful for the decision made during surgery. And as we see it, this type of testing can be verified only when we speak about the resection margin, positivity of resection margin, when we speak about organ sparing or just plastic surgeries. Subsequently, it is not valuable diagnostically. It is clear that in order to do deep diagnostics, we can use contemporary methods of immunohistochemistry, which once was seen as a panacea which will solve all the issues, but it turned out not to be a panacea, but nonetheless it's quite helpful in a number of issues. When we speak about neoplasia of the pancreatic gland, we use a group of antibodies, for example, cytokeratines, which enable us to assess the type of epithelium and its products in the phytoprotein alpha, in AFP, trypsin and the CEA, another group of antigens, which allow us to assess the antigens related to the mucin production. It's because the mucin profile or production by other different cells. Sometimes it's of big significant neuroendocrine markers, which allow us to do the diagnostics of the tumors with epithelial carcinomas. And another marker, PAX8, at the moment is used in order to detect metastasis of neuroendocrine carcinoma in the regional lymph node metastasis. When it is detected as a positive transcription factor, then with a significant, it's not only the neuroendocrine carcinoma, but the neuroendocrine carcinoma can be detected as the one originating from the pancreatic gland. And last but not least, immunohistochemistry is used in order to detect the extent of or the grade of malignancy. The tubular solid alveolar type of tumor with low differentiation, the positive trypsin expression and antibody detection to chromogranin A shows that it's a mixed type of tumor, acinar and neuroendocrine. So it has two histogenetic elements in one. Algorithm of morphological diagnostics. I would like to show our experience, the experience of our lab that was initiated about 2 years ago with the endoscopic department run by Dr. Solonitsyn. That is why a great number of studies have already been done. And when we speak about diagnostics of the material that was sampled for our laboratory testing, we conduct a complex testing which includes traditional cytology with a staining of azure blue. And this is actually a conventional type of cytology. And this is something that we as well perform, but its significance, its value is somewhat lower than other diagnostic methods. Liquid cytology, pap smears is also done as second stage or second step. And it's very well applicable in brush biopsy. And also if we study the contents of a cyst. Immunocytochemistry is not something that we welcome very much, but for certain reasons we use it, especially when it is impossible to do the clarification by means of other immunohistochemical methods. As we take into account, we should take into account the cell block preparation with further histology. Immunohistochemistry is not something that we consider because we actually do it within the cell block study. The information value gives us great advantage because if you take isolated cytology study, then low information, it's low informative or non-informative in 33 and respectively 16.7% of cases. And if you add to this uninformative cytology some other cases, it will bring the significance of cytology as a diagnostic method to nil. And if we use complicated methods, then this problem can be reduced to 5.1%. Now you can see what equipment we use, the cytocentrifuges, after which we perform the densification of all the tissues in this liquid media by means of centrifuging, and we receive a cell concentrate and everything that was sampled within this procedure. After that, according to certain methods, we form it in a block, and we treat it similarly to small biopsies, and after paraffin embedment of the substrate, we do the traditional histology with hematoxylin, or if needed, we conduct complex immunohistochemistry of the same specimen. So the main element of this complex study is producing the cell block, which is not part of the cytology study, but it's a histology study. But we use small needles of G22, 18, 25 sometimes. So these bioptates concentrate in this cell block with other cell elements which we enable to collect within the same fluid by means of centrifuging. This is the method, and according to our data, 2/3 of the tumors, or bioptates rather, that we conduct were for solid tumors of the pancreas, then in 21% of the cases cysts of the pancreas, then in diffuse lesions, 7% of the cases, and the rest are lymph nodes or papilla problems. And a couple of slides. We should understand that when the needle penetrates the mucus, it also collects certain liquid in the root. So a morphologist should understand that in the histology block there will be certain in-root tissues which has no relevance neither to the pancreas nor to the tumor. And this is just an element of the mucus of the duodenum and stomach. And the bioptate also can include unchanged tissue of the pancreas, which in cytology can be verified very easily, or in histology you can see unchanged pancreatic tissue as one of the elements of assessment the changes in the pancreas itself. Now, please pay attention. These are cell blocks, and this is the material volume. You can see something that was demonstrated in the previous lecture. There were also elements of cell blocks demonstrated to you. If we speak about ductal carcinoma, both cytology can be very demonstrative, and we can be pretty sure that this is a carcinoma, and also smaller bioptates can be detected of atypical glands, which can retain the structural components and also allow us not only to determine on cytology, but also immunohistochemistry, chemical structure can be detected. And you can see here the ductal carcinoma of the pancreas. If we have two tumor components in the same gland, then we can suspect them. In traditional cytology, can have certain groups of cells in the glandula or in the gland. Here we can see that it's not just a ductal carcinoma, but we have squam cell differentiation here. So this is glandular squam cell carcinoma. If we speak about cystic or mucinous neoplasms, the diagnostics of which is very complicated. It looks like this. This is a microscopic specimen, and in CT and EUS, when we have the specimens for cytology, then take into account that the mucinous carcinomas are never accompanied with nuclear cell atypia. The tumor doesn't have any significant signs of anaplasia. In order to classify them as carcinomas. So generally speaking, it's very difficult to diagnose, especially when we speak about borderline or high differentiated tumors, and we use selective staining. that we use both in cytology and histology material. And in the cell block, for instance, here we have great number of glandular structures or tubular structures that are formed by mucinous epithelium with the signs of atypia, which can be assessed as a mucinous carcinoma of the pancreas. Now, in neuroendocrine carcinomas, you can see how hectic the cells are. There are certain groups or clusters, rather, which have some solid structure in the cell block, and the immunohistochemistry in the cell block will allow you to confidently say that we are here speaking about neuroendocrine carcinoma, and further on we just grade the malignancy. Now, what we have already seen, the biopsy of the lymph node, this is a regional lymph node which was obtained after EUS. So you can see immunohistochemistry of the same lymph node specimen, which enabled us to assess it as a secondary metastatic process with a primary tumor of the ductal immunocarcinoma of the pancreas. And the tumor lesion of the pancreas as a bright example of a patient who previously was operated on for the testicle seminoma with very big specimens. This is a small biopsy result, and after immunohistochemistry, we can confidently diagnose the herminogenic type of tumor, and we can detect that in the pancreas we have not the primary tumor, but the secondary tumor, which is seminoma metastasis. And in the conclusion, I would like to say that the morphological diagnostics of the pancreatic gland malformations form a very special morphological direction. This is one of the fields of gastroenterological pathology, the so-called. And in order to improve the diagnostic accuracy, we should develop specialized pathological anatomy studies, and the qualitative diagnostics and results improvement are possible in the complex testing, including cytology, histology, immunomorphological approaches, molecular genetic methods, and liquid cytology, which I've already talked about. And in the very end, I would like to show the group who I work with. These are people who are gastroenterologists and lab specialists. As today we are talking about some very young directions like EUS, I mean young in the field of medicine. Look, we have young people in our lab, young specialists who deal with these complex studies. You can see cytologists, molecular biologists, lab assistants, specialists in the ICH. And I suppose that this multidisciplinary approach really helps us to be successful in our work. Thank you. Thank you very much, Sergey Leonidovich. Dear colleagues, any questions to this speaker? The questions to the pathologist. Can we put up the lights, please? Dear Sergey Leonidovich, thank you very much for your talk. You have mentioned a lot of things that really correspond to our idea of multidisciplinary approach and working together. Your opinion of the cascade. Once again, I know your publications very well, your style of morphological assessment. It's quite interesting and quite original. What do you think, being a pathologist, about this cascade? Because there were several revisions of this cascade. What do you think about it as of today? because we have already mentioned it, and I cannot but ask a question about it. So when the process is advanced inside the cell nucleus, most of the mechanisms are still unknown to us, and they're interepithelial, and they happen within the duct of the pancreas. Generally speaking, clinically, they are not very significant. That is why patients do not come with presenting complaints with some typical or atypical symptoms. So it's very difficult to detect this by clinical manifestations, but between the moment when the obvious malignancy occurs in the ducts and until it grows into inoperable or unresectable tumor, there is quite a long period of time. So I do think, just like in the bowel carcinoma, it can be quite long period of time, up to several years. So from the clinical and morphological comparisons in the very last cascade, you agree with that? Yes, I do. Dear Sergei Leonidovich, coming back to the method that you have mentioned, we do understand that this is much more informative than cytology, and that it has certain, bits of tissue, so probably changed because of the centrifuging. If we speak about oncology, this method will probably have an advantage if compared to cytology, but I'm a GI specialist, so I'm very interested in pancreatitis of the second type, for instance. How informative biopsy would be in liver inflammatory disorders, for instance. Thank you very much, Karina. And I am quite sure that as soon as we reach safe level of EUS with FNA, as soon as we reach standardized procedure, and as soon as we understand that there is very low risk of a patient to develop problems, then biopsy of the pancreas in the non-tumor pathology will become a golden standard, just like bowel biopsy when an endoscopist does not see anything inside the bowel even. Thank you very much for your talk. For the first time, I hear such wonderful presentation about pathomorphology. I'm head of the department of MIS, and actually, we have about 200 cysts, and we puncture them, and we have about 100 patients who we diagnose and operate on in our department. At the moment, we do not have problems with diagnostics because we have a good cytologist, but after listening to your lecture, I cannot understand it to myself. If we'll take a liquid or cyst type malformation and we send it to cytology, don't we? And you make a cell block, if we do sonography, 200 per year, as we do, then if we perform FNA, we receive a material that we put on slides, and also we send it to the cytology lab, don't we? If we take 18, 16 gauge needle and make a biopsy, then we send it to a pathological lab. So all 3 times I noted to your questions, it should be no, regarded as no, not as yes. And it's related to the following. By asking this question, you demonstrated the biggest problem of the morphological diagnostics in Russia, where cytology is not part of the morphology. It should be inside pathological anatomy as part of morphology, actually. So there is no separate cytology with a good cytologist and histology with a good histologist. There must be one morphological laboratory, which should include one and the same team of doctors who would be doing it, because they are specialized. That's why we have good quality results. Because we don't only have complex approach, but complex understanding of the process, which we see either in histology or in cytology. And another question then, again, I'm a layman in this. We see a lot of pathologists all over the world who are part of the surgical team. They are inside the operating room and they immediately assess the material which comes from the puncture biopsy. As far as I understand from your talk, it's not reasonable. No, it's not reasonable at all. My significance as a pathomorphologist will be much bigger if I invest this time being at a microscope, and I can result in 10 additional diagnoses. We should exploit a pathologist at a microphone, not in an operating theater. So please exploit us more. But you know that the kidney biopsies are done by my laboratory from your hospital, by the way. Yeah, that's just about cooperation.